should always have a good reason for doing robotic surgery. You should never choose to do robotics because you think it's a good marketing tool or you think it's just something cool to do without a good reason. It takes a lot of commitment to get through the learning curve and to maintain the credentialing and privileging with robotics. And so if you have a good reason for doing it, then it'd be much easier to maintain that pathway.
You need to know what the limits are, because every case is not a case for robotic myomectomy or any robotic procedure. You don't want to end up setting yourself up for failure, because that will make you frustrated, it won't be good for the patient, and that will discourage you from coming back with your next case, because you'll be going home and say, what was I doing in the OR all day?
One procedure does not fit everything. So in the US we have a saying, if you have a hammer, then everything is a nail. And so my hammer is a robot. So if I have a robot, then everything I can do is with a robot. And I need to recognize that the robot is not the answer for every case.
Any planning cycle begins with an assessment of what you have before you plan on what you need. So that's what you need to do. Second thing, obviously, in all organizations in the public or private sector, resource allocation is a major issue. So we need to be able to allocate the material, we need to allocate the manpower, and we need to allocate the people that you can send for training.
Once, I must tell you, I followed onto a robot after the gynae had done a case. The gynae have their settings upside down because they are operating in the pelvis, and I forgot that settings were on, and I sat on the console to do my things, and for 10 minutes I couldn't figure out why this robot is not working. I just couldn't figure out till my wise man there said, sir, they did a gynae case, it's upside down. Everything that you're doing is upside down, and that's when I realized that actually I have to change the settings. We are like pilots in a cockpit, and before you start the case you have to check each and every equipment and make sure that it is working fine. Pilots do it, that's why planes fly, and that's why their error rate is less than 0.1%. The error rate in surgical theaters is about 4% internationally, and there are a lot of business models which are looking at using the pilot technology, the pilot technique of doing a checklist. So we do a WHO checklist in our theater for each and every case.
It is rightly said that, as the surgeons keep moving ahead, the anesthetists also have to keep in pace. So the important takeaway message in this is that failure to check the equipment properly before induction of anesthesia is responsible for 22% of the critical incidents that occur during anesthesia. So we have to ensure that the equipment is working properly and giving us the right information.
It's not just a trained anesthetist or a trained surgeon. Another trained person is absolutely vital, and as you rightly said, after the anesthetist is done with his or her job, it's your colleague who takes over, and he's the one who actually decides all the ports and this, that, and actually manages the show there while you are away on the console. And every team has to have one such member who should be a regular part. There is a drill which is rehearsed between the two, that in case of a mishap, these would be the steps, 1, 2, 3. If there is a bleeding, this is what he would do, this is what I would do, which only occurs when you have the same person present all the time.
You can't have people rotating, on the robot on Monday and urology on Tuesday and, orthopedic surgery on Wednesday. It's got to be a team that's consistent. Rather than having them learn on the job, they really need to be familiar with it ahead of time. Another very important thing is who's the assistant. You need to have assistants who understand how the robot works. So you can't have a resident on his first or second day thrown in the robot room to assist you, because they need to know how it works mechanically and functionally, how to change the instruments, and they also need some laparoscopic skills, because they're going to be helping you.
We always do MRIs as well. It's really worth the time to do that, but you need to talk to the radiologist and tell them what you're after. They'll just order an MRI because they'll say multiple fibroids. Call them and say, I need the exact number of fibroids, and pinpoint the location the best you can.
One way to preempt that problem is we do preoperative MRI, so you kind of precisely know that. And then you can import that MRI into your console and to the tile pro, and that way you can see that you've taken them out, and the other way would be to use the ultrasound.
What's beautiful about an MRI, especially if you have the luxury like we have at Ford of having it online in an electronic medical system that everybody has access to in the system, is to sit with the patient. Even the non-initiated can see what it is on an MRI image and scroll through and really explain to the patient. I find it to be very valuable.
In order to, I think, have a successful robotic liver resection program, we have to understand the principles of laparoscopic liver surgery. And if you can, really absorb all these concepts, then, incorporating the robot into that practice is not going to be difficult.
It's good to do a team dry run before the first few cases, and also to do a team debriefing after the case to say how things go, what went well, what didn't go well, what can we do to improve it. That's very important when you're starting the program.
Very often I tell him, do something, and he's not doing it because I'm looking down and I don't know that the arm is clashing there. Do you know what I mean?
Sure, it happens.
So,
numerous times it happens
Over
that...
time we have evolved and overcome this problem.
In fact, what he did was, he got a procedure recorded from outside of what he was doing. And then he said, sir, see this.
Yeah.
This is the problem. You don't seem to understand when you're on the console. What is the problem that I'm facing? And it is absolutely
It is why
right.
it is mandatory to have
important
proper
know that.
communication and understanding of each other.
Well, I think it's very important preoperatively to know exactly what you want to do, and will you go to the artery, will you do selective clamping, will you go ultra selective, clip it at once or not? So these are the different questions. So you must have your strategy before you start. So it's important to have this.
Have a plan for complications ahead of time, not after the fact. Complications, cystotomy, bowel injury, intraoperative bleed. Just kind of have those. Even laminate them. Laminate them and just stick them on the console so you don't have to think about it. Okay? So you know what you need and your team knows what they need if you have those kind of things. Because when that stuff happens, your heart rate tends to get up and your brain tends to think less clearly. Fibroid management, consultants are always nice if you have people who are robotically trained. So just realize that with robotic surgery, complications does not equal conversion. Okay? Don't panic the first time you get a complication and say, oh, that's it, we got to open. Realize that you can pretty much get done whatever it is that you were going to do with an open technique robotically.